Good morning, everyone. I think we'll get started. Uh, Welcome to Grand Rounds. Please sign up for Grand Rounds next week or for cardiology rounds next week. Dr. Justin Moraine from the Division of Endocrinology is going to be talking about testosterone and cardiovascular risk. So please sign up for next week's rounds or attend in person, even better. So today it's my pleasure to introduce one of our third-year cardiology residents, Dr. Keiler Totz. He's in his third year of his cardiology training and will be going on to do another year in sleep medicine come July. He's in the midst of his cardiology exams, so we thank him for presenting today. Stressful time of year for him. Anyways, welcome so much, Keiler. And today he's going to be talking about obesity medicine for the cardiologist. So welcome.
Excellent. All right. Good morning, everyone. Thanks for taking the time to attend rounds today. So let's see if I can get this guy to work. Perfect. So starting off, I was trying to piece together in my head what I thought could be helpful to discuss in regards to this topic. And we know that there's an increasing body of evidence these days supporting obesity as a causal risk factor for many types of cardiovascular disease. And obesity medicine is an evolving field that many of us in attendance have likely had little to no formal training or exposure to in the teaching aspect. And yet many of our patients these days are presenting with overweight and obesity. So it's probably one of the last frontiers of cardiovascular disease prevention that we haven't routinely incorporated into cardiology practice. And the two main focuses of today's talk would be to review some guideline-based obesity medicine, specifically out of our Canadian guidelines, as well as explore the interplay between obesity medicine and cardiovascular disease, relying on some of our more recent ESC, obesity and cardiovascular disease statement summaries. And then just a quick note, hopefully I'll be able to convince most people in the audience that we should be at least exploring the option of prescribing GLP-1 receptor agonists in some of these future incretin therapies, given their increasingly proven benefit in significant weight loss alongside cardiovascular disease. And I've put together kind of a quick double-sided sheet for prescribing first time and how to follow this along to help encourage people to feel a little bit more comfortable with these medications, especially with many patients now asking us about our expertise and knowledge around this. So to start off with, what does this picture look like? So obesity prevalence right now in the adult world is about 1 in 5. We know within Europe, this is about 22% of the population. In Canada, this bumps up a little bit higher, about over a quarter of our patients. And unsurprisingly, unfortunately, the US is one of the highest prevalences of obesity in the adult population, over 40%. The trends and prevalences between sexes does vary regionally. So we know that the overall prevalence is similar between sexes in Canada and Europe, but globally it tends to affect women more than men. Within this, we do know that severe obesity, which is defined as kind of a WHO class 2 obesity and above, so BMIs of 35 and above, it's more prevalent in women, while milder forms of obesity are more prevalent in men. Unfortunately, we know that the prevalence of obesity has been increasing, and globally it's doubled since 1990, and Canadian data shows that it's more than tripled since 1985, with the greatest increase in patients who have severe forms of obesity, with 4 to 5-fold increase since the mid-80s. Now, definitions of obesity. We want to move away from this concept that obesity is BMI, and we'll talk a little bit more about why that is later on. But really, the definition centers around this abnormal or excessive adipose tissue, fat tissue accumulation that impairs health. And with our Obesity Canada guidelines, we want to emphasize that this is a chronic disease, relapse remitting, that's related to this excess adipose tissue that does impair health in terms of its biopsychosocial functions, and it does reduce lifespan and increase morbidity. Another key point is that obesity is both a disease in itself as well as a risk factor for many other diseases. Now, obesity-related complications, something that we'll really highlight today is that patients living with obesity are at about 50 to 100% higher risk of mortality compared to age and gender matched patients of normal weight. And about 2/3 of this excess mortality is related to cardiovascular disease, which is why obesity is firmly within the wheelhouse of cardiovascular disease medicine. So we kind of have to champion prevention and probably primary and secondary approaches. Another area that is worth exploring, especially in terms of patient education, is its impact in terms of cancer. So we now know it's causally related to at least 13 types of cancer, thought to be a result of many of these adipokines that are released and many hormonal growth factors in response to this. So this is something that oftentimes patients may not be initially aware of, that is important for them to know when taking control of their own health. And then many of us are more familiar with the metabolic complications of obesity in terms of type 2 diabetes in that spectrum, as well as, obstructive sleep apnea, obesity hypoventilation syndrome, and then its impact on gallbladder disease, as well as the full spectrum of chronic pain, osteoarthritis, and the impact of mental health disease. So this is a slide trying to highlight the classification of obesity. So again, not the definition that we should be using these days based on BMI, but a way that we can help classify patients when we're starting to encounter them in clinical practice or in research settings. So the World Health Organization used to only go up to class 3, but with that increasing prevalence of more severe forms of obesity, we've now expanded that and we're kind of leaving that open-ended side at obesity class 5 with BMIs at 60 and above. And then we'll talk about some of the interplays between body composition and adipose tissue distribution, and why certain populations, such as those of Asian ethnicity, will have lower cutoffs for overweight and obesity, which is important to know when we're seeing patients in practice. So this slide helps highlight the 3 main tissues that come into play when we're talking about adipose tissue. So we really have the white adipose tissue, which is for the most part metabolically inactive and is mainly there in terms of its mechanical insulation, as well as brown adipose tissue, which is more metabolically active and involved in thermogenesis, as well as this concept of beige adipose tissue, which is actually originally white adipose tissue, which through time and exposures to certain triggers, and we have some evidence now for chronic cold exposure as well as chronic exercise exposure, we can help induce this brown fat-like transformation, which can help improve thermogenesis. Because we are in the Heart Institute, I felt it would be remiss not to include at least one PET image during these rounds. So this is actually a nice slide for a smaller study, but it does highlight the distribution of brown fat in the adult body. So they were actually looking at chronic mirabegron treatment, one of these beta agonists used for overactive bladder. And you can see here that on the initial day, they're trying to identify where are the stores of brown fat in the adult body, and can we help stimulate this to see if we can get improvements in terms of metabolic function, thermogenesis, and while the study wasn't long enough to look at weight outcomes in the end, it did clearly show that treatment with this beta agonism did improve these supraclavicular locations in terms of the amount of activity of the brown fat. It's also prevalent throughout the mediastinum as well as in the perinephric regions. Now, in terms of the distribution, so another important concept to keep in mind is that the same BMI can lead to a very different disease process, and patients can look and metabolically behave very differently despite having the same weight, the same BMI, and even the same fat percentage when we look at certain imaging modalities like DEXA or cross-sectional imaging with CT and MRI. So this subcutaneous and ectopic fat storage tends to be under the skin is what we think about when we view people from that lens of are they living with larger bodies or not. Whereas the ectopic fat storage tends to be locations such as the liver, the heart, intramuscular, as well as this concept of visceral adiposity and central obesity. And we know that unfortunately this visceral and epicardial intramuscular fat is much more metabolically active, oftentimes with deleterious effects in terms of our metabolic function. And this is just a quick image here showing that these patients who do have the same BMIs, and even in many cases the same fat percentage, the distribution between the subcutaneous and ectopic spaces does dramatically impact their metabolic profiles. And that's something that we'll explore further here, as we now know that visceral adiposity has been related causally to increases in terms of atherosclerotic cardiovascular disease, LVH, OSA, as well as the host of metabolic complications from hypertension to dyslipidemia and diabetes. So this is a concept that I was first exposed to through Peter Attia. I know some of you in the room may have read Outlived or listened to the Drive podcast. He's one of the more prominent primary and secondary prevention physicians down in the US who had a bit of a non-traditional pathway to medicine. But he likes to talk about this concept of the bathtub when it comes to thinking about fat distribution in the body. So a crude analogy when it comes to energy intake and outtake, I'll admit that. He talks about, the faucet being on is the energy intake into the biologic system, and then the size of the drain is the amount of energy kind of being burned or used. And then this leads to the accumulation of water. And the real goal to this analogy is the partitioning between the subcutaneous space, which represents inside the bathtub. Having water inside of the bathtub is safe, right? There's no damage to the floors. It's meant to be there. Our bodies know how to handle this. And everyone, based on their ethnicity, their genetics, as well as environmental exposures, will have a different size bathtub. So we know that people can live with different sized bodies with different metabolic impact. As some people have a propensity to store lots of this adipose tissue in the subcutaneous space where it is safe and metabolically inactive inside of the bathtub. And we start to run into issues when you have reached the limit of your own bathtub and it starts overflowing the sides and damaging the floorboards. Now we start getting ectopic fat storage within the liver, around the heart, and this leads to those metabolic complications that we fear. So this is something that I sometimes bring up to patients when they're trying to figure out, what does this mean? Where is fat tissue stored? Is it good? Is it bad? And some of the misinformation around this. So some of the pitfalls of BMI. Now, BMI is really just a measurement of body size. It tells us nothing about the distribution of adipose tissue or the metabolic and non-cardiovascular complications of obesity. Obviously, it's going to be misleading in certain situations and certain ethnic groups, especially those with higher or lower body mass, especially when there's muscle mass involvement, patients who have edema or ascites that we commonly see within the realm of cardiology as well as hepatology, and then patients with pregnancy, and then also those on the outliers with more severe forms of obesity. A more accurate measurement that is also a bedside test and something that most of us have probably not done in clinical practice ever because it's not taught in physical exam in med school, but it's the waist circumference. So we know this is better at identifying central adiposity, which is something I'll hopefully keep emphasizing as one of the main obesity phenotypes that we need to be aware of. And then, as with anything, we need to take certain cautions when interpreting this, knowing that fluid or food intake, so measurements right after lunch, may not be the ones that we want to hang our hats on, and then thinking about bloating, ascites, and pregnancy. And then patients with normal BMI can present with increased waist circumference and central adiposity. And this is termed the normal weight obesity phenotype. And this plays into why certain patients of different ethnic backgrounds, especially Southeast Asian populations, we need to consider that they can have obesity and its metabolic complications, even when they may not have been classified as having the larger body size based on traditional BMI categories. So it's important to know that we should be thinking about measuring waist circumference in all of our patients, but especially those with at least overweight with a BMI over 25. Now, when we start getting to more severe forms of obesity with a BMI over 35, while the waist circumference likely adds little to the diagnosis, it can be a very helpful metric for patients to track. As we know, with lifestyle and pharmacologic interventions, we may start to see changes in waist circumference and body composition before we actually see any changes in their overall weight or their BMI. So this can help reinforce certain interventional changes and help reassure us that we're transitioning towards a metabolically safer phenotype of obesity. So just a quick note on how to perform a waist circumference. So when I was trying to figure out how to do this, reading through the guidelines, it was really just a lot of text. Like, I don't know, for those of you in the room, when you read this, is that intuitive to you, right? Everyone has a rough idea of, you're supposed to kind of measure around the central portion of the abdomen and such. And, but I was kind of going through being like, all right, I'm palpating the iliac crest. Where am I supposed to measure? So something that I found very helpful, and surprisingly, there's very few resources in terms of audiovisual format, but on YouTube, the National Health Service out of the UK, they put together a nice, succinct YouTube video on how to measure a waist circumference. And this highlights some of the key kind of anatomic landmarks in terms of thinking about the mid-axillary line, the top of that iliac crest, and the bottom of our ribs, and using that as our central marker for measuring things. And while it may seem quite straightforward, if this is something that we're planning to incorporate into practice, which we all should be, it's worth practicing it, as there's nothing worse than fumbling with a tape, not knowing how to approach patients, hugging them from the back or from the front. For the first time in my life, I have a number of weddings that I've been invited to, and I was just at Moores over the weekend getting a rental suit. So I kind of asked the seamstress there, do you have an approach? How can you make this easy for patients or people of different body sizes? So something that's very helpful for patients. Yeah, most patients will have overweight, obesity. You can ask them to hold one side of the tape measure, and then I just ask them to slowly pirouette in place. And this way you're not kind of coming in at all weird angles, and it just avoids any of that. And it seems much more professional and smooth, and like what you're doing. So in terms of the waist circumference and how to interpret this, so this is a table that has been validated for certain patient populations and ethnic backgrounds, and kind of the numbers that we most commonly encounter do tend to be kind of the American and Caucasian numbers that we're familiar with. And one point to note is oftentimes we'll see in notes when people are discussing waist circumference, if we do incorporate that, we start telling patients, we're aiming for a waist circumference around 102 centimeters in men and 88 centimeters in women. The ESC kind of cardiovascular disease guidelines break that down further and say, there should be a bit more of a dichotomy. We're really trying to encourage ongoing weight reductions when we're at those thresholds of 102 and 88 for men and women. And really, it's at the thresholds of about 88 centimeters for women and 94 for men, where we're comfortable with them at least maintaining that level of central adiposity. So really, it should be encouraging weight loss at the higher value here, kind of outlined with the red boxes. And then when we're closer to the blue boxes, that's where we're not pushing as hard specifically for central adiposity tissue reduction. Now, this is another staging system that isn't commonly talked about. Many people are familiar with BMI, but the Edmonton obesity staging system has actually been proven to be more closely associated with overall mortality than just BMI or waist circumference alone. And it's a nice model because it incorporates both the mental, metabolic, and physical impacts of obesity on patients, which is oftentimes what they're worried about, right? They're not just worried about a number on the scale, it's about how it impacts their daily living and their overall health. So we'll talk about this in a little bit more detail later when we go through kind of a treatment approach based on the Edmonton obesity staging system. But just as a broad overview, stage zeros tend to be viewed as a metabolically healthy obesity. So these are patients where you have not yet been able to identify any significant complications such as hypertension, dyslipidemia, or diabetes and insulin resistance. Stage 1 tends to be subclinical disease or mildly symptomatic patients. And then when we start getting into stage 2, these patients now have established end organ dysfunction or associated adiposity related disease and moderate degree of symptoms. Stage 3, we now have more significant end organ dysfunction and significant symptoms. And when we start getting to the Edmonton obesity stage 4, that's where we kind of have this end stage palliative level patients. We all think about kind of common media portrayals of patients living with obesity and how this can have a very severe impact on their life. And this is the category when we're starting to think about inability to mobilize and end-stage heart failure or, liver transplant for metabolic associated liver disease. Now, something that's worth knowing kind of on the cardiovascular severe is different imaging modalities for fat topography. So for us, within all modalities of imaging, we have ways to at least get a sense about the impact of adiposity on health. All of these are still investigational at this time, and none of them have been incorporated practice, but we may see an increasing use of modalities, especially CT in the future. So PET imaging is one area that can actually provide direct inflammatory imaging as well as functional imaging, similar to that picture I showed about the brown adipose tissue and the function based on PET. And then CT can actually provide this indirect evidence of perivascular adipose tissue inflammation with this fat attenuation index. We'll talk a little bit more about that in the next slide. Practically from like an echo perspective, I know many of us, when you start getting into the reading room, will say, oh, no pericardial effusion. But if you look, the vast majority of patients will have quite significant epicardial fat pads. And we do have some data now that in patients with an epicardial fat pad thickness greater than 9 millimeters is associated with much more significant metabolic dysfunction, as well as elevated filling pressures, in keeping with the physiology about pericardial restraint and taking up more of that space with adipose tissue. So within CT, this is a nice image from the ESC breaking down the different distributions of adipose tissue within the chest wall cavity around the heart. And we now know that either perivascular adipose tissue, especially with this fat attenuation index, or just the total amount of pericardiac fat can be associated with the incident amount of MI, independent of a patient's BMI, as well as overall cardiac mortality. So some of this data comes from the CRISP CT study back in 2018 in the Lancet, and this is where they were really validating that fat attenuation index, showing that it does correlate with future cardiac mortality, even while controlling for coronary artery calcification. It's more of a radiology perspective, and again, still investigational, but they tend to use a cutoff of about 70 Hounsfield units. All right, so let's talk a bit about the drivers for obesity. So we know this is a complex disease with multiple different underlying pathophysiologic mechanisms. Again, another nice graphic from ESC kind of highlighting that there are many neuro, bio, psychosocial factors associated with obesity. And we now know that, these socioeconomic disparities, including lower educational attainment, are strongly correlated with obesity, especially within developing nations. These financial, societal, and social network factors also influence our individual decisions regarding energy expenditures and energy consumption. And then this rapid rise of obesity, the obesity pandemic, a key point of discussion is that while there are underlying genetic and biologic factors, it's really been driven by social and environmental change when we think about why do we look different than generations before. So we'll try to explore a bit of that now. So while commuting into work this morning, things may have looked nice and sunny and green out, and hopefully this will be the view that we can all take moving forward in the future. But unfortunately for many patients, especially those living with overweight and obesity, modern society feels more like this for them. So there's a plethora of different underlying factors that lead to this obesogenic environment. Many of them related to the food environment, thinking about the rise of this prolific and easily accessible landscape of ultra-processed foods that tend to be very low nutrient density, but very high calorie density, alongside this 24/7 delivery service availability and always having excess calories at our fingertips. And then thinking about portion creep. So I was lucky enough to spend some time in Japan with my brothers after finishing the written Royal College exam to celebrate. And let me tell you, portion size there is dramatically different than here, which is also dramatically different than several areas of the US. My brother spent some time studying closer to the southern parts of the US, and when visiting him, it's quite apparent how some of this can have an impact on our daily energy intake. Another part is this predatory marketing that we come into play that starts even in childhood. And we'll talk a little bit about how that's actually strongly influenced by the tobacco industries, and how, back in the days in the 80s and 70s and such, many US children under the age of 6 were more familiar with Joe Camel than they were with Mickey Mouse. And that's happening these days when you think about all these healthy or quick on-the-go snacks and food products marketed at children that are flashy with cartoon characters. They have Sonic branding to them. So when they think about that nice crisp crack when you're opening up like a diet soda and such, or the opening of bags, all of these things designed to help hook us on these ultra processed foods. Then also food deserts, which is a big consideration, especially areas of lower socioeconomic attainment. The built environment, obviously, it's very much a car-dependent world that we live in, some cities being better than others. And then many of these modern conveniences, for many intents and purposes, while we're up walking around most of the day, a lot of my colleagues that work outside of medicine, they can sit down at 8 a.m. in the morning and have not stood up all day at 5 p.m. when they finish the workday, food eaten at the desk. They don't have to open or close windows with, air conditioning, and they don't have to worry about things. They can control their laundry machine from their phones. So it's just these modern conveniences are obviously helpful, but we have to acknowledge their impact on reducing our non-exercise related thermogenesis and energy expenditure. Then the modern work culture, especially within medicine, when we think about chronic stress, sleep deprivation, as well as screen time, these are all things that dramatically increase our amount of sedentary behavior, as well as helping promote our tendency to reach towards higher calorie satisfying foods. And then as well as many of the societal norms, when we think about these maladaptive eating patterns. So, for many patients, when you ask about family habits, if you go back a couple of generations, a lot of the food was consumed at home cooking, family time discussions. Now, if you talk to families, or especially doing my, congenital cardiology rotation at CHEO, and you ask some of these kids, what does it look like? Well, they eat while they're sitting there on their phone watching YouTube. They don't think about what they're putting in their mouth. They try to eat as fast as possible so they can maximize their time playing video games and stuff. And unfortunately, many of us in the adult world aren't much better, right? A lot of us eating alone and eating quite quickly and not being mindful of what we're eating. And then this kind of prevalence of snacking, which is kind of pushed by industry to help encourage us to consume more products when snacking wasn't exactly something we used to do in the past. So this is just, my attempt at a public service announcement. So we have this lovely CBC kind of docuseries, The Nature of Things. And actually just recently they released this Foodspiracies documentary. So I sent it to a few of my family members, and it's about 40 minutes. So, if you're gonna watch YouTube, you might as well pull this up while watching dinner or lunch one day. And let me tell you, it is mind-blowing. They're talking about, over 50% of calories consumed by North Americans and specifically Canadians are coming from these ultra-processed foods. And there's only about 15 to 20 companies that control all of these ultra-processed foods, many of which were bought up and owned by tobacco companies when they started to come under fire for addictive behaviors and cancer-related risks from tobacco products. The working definition of ultra-processed foods is actually quite straightforward. If you read the ingredients list and you find any ingredients that you would not find in a home kitchen, then it's an ultra-processed food. And when you apply that definition, you may be shocked at how much of what you're eating that you may have thought was minimally processed or healthy actually qualifies as an ultra-processed food. And that's very different than processed foods. We've been drying and salting and fermenting foods for decades, and that has a much different metabolic impact than these ultra-processed foods that really started to rise in the mid-1970s, and these days are prevalent no matter where you go. And it's important to know that everything about these foods has been specifically engineered to increase consumption of them. Everything from the advertising, packaging, the sound, the color of them, the feel in your mouth, the texture of these foods, and the composition. So many of these food scientists, they're using functional MRI to assess reward and pleasure pathways in the brain. They have huge sampling populations comparing just the color of a drink or just the convexity of a chip and the feel in your mouth as you crunch down. This food scientist coined this term called the bliss point. There's this Howard Moskowski back in the 1950s. And it's the specific ratio of fat, sugar, and salt optimized to create the most addictive response to food. And this is what industry designs for. They try to optimize the bliss point while minimizing any of the high expense ingredients that tend to be whole foods. So they find all sorts of filler products to help achieve this end goal. And then something I must say, so after reading this New York Times article here, The Extraordinary Science of Addictive Food, and they based it a lot around a case study of how the modern chip evolved, I can't recall the last time I ate a bag of chips. That evening, I got back from the sauna, and it's like 10:30 at night. I was just driving home, passing by the grocery store that I pass by every day, and all of a sudden I was hit with this intense craving, and I was like, I need a chip. 15 minutes later, a whole bag of Lay's chips lay completely demolished in my car. I hadn't even left the parking lot. So I must say, obviously an N of one here, but these things have a profound impact on our neurobiology, and we'll talk a bit about the science of obesity in a second here. So when it comes to genetic factors, we know that there are well-established obesogenic syndromes and monogenetic causes, with about 11 different causes for obesity being identified, as well as some of these syndromes that we may encounter in kind of the congenital sphere. Parental obesity has also been linked to adulthood obesity in children, and we're starting to think now, while the actual underlying genetic composition hasn't changed, these epigenetic changes that are occurring as we change our food environment can be passed down to our children, which does tend to change their own internal set point for their weight. And that's how we know these genetic factors will influence internal weight set points, as well as the degree to which we're able to resist this obesogenic environment. Now, the neurobiologic factors, the science of obesity is actually very complex. For Peter Liu, who wants to explore the heart, brain, gut interconnectome, this is probably a key area to look at because everything is connected when it comes to obesity. And many of the scientific fields are still emerging. But there's three main biological factors that I've tried to distill it down into: the brain, the adipose tissue, and the gut. So not a neurologist or a neuroscientist, so I try to keep it relatively straightforward here. But there's also three key areas when we're talking about the neurology and the brain involvement. So the first is the hypothalamus. And this is really our homeostatic set point when it comes to weight. And specifically this area, the arcuate nucleus, is our hunger center. And that helps trigger food-seeking behaviors. We move on to the mesolimbic system. This is our hedonic center. And this provides reward and pleasure associated with food. And this is the driver when we start thinking about food cravings, even when from a biologic perspective, we've consumed enough calories to survive. It's also tied to this concept of emotional and environmental triggers leading to eating, influenced by this dopamine release. And this really ties into the desire to eat foods as well as the anticipation of eating. We've all had that moment, you're sitting in rounds or you're finishing off reviewing the list, thinking about what you're going to eat for lunch or what you're going to have for dinner that night, and that building pleasure associated with anticipation. And these dopaminergic neurons are also acted on by some of the endocrine factors like our GLP-1s, leptin, and insulin. And then the actual consumption of food releases these endocannabinoids, leading to the pleasure associated with eating. And we know that many patients with obesity do have this upregulated anticipatory response to food. They really think about it and crave that food, and yet they've had a downregulated response and kind of reward to eating. And this imbalance of always wanting more and yet not seeking the pleasure they wish is one of the key driving factors for overconsumption and overeating. Now, when it comes to the cognitive load, this is really our executive functioning, and this is our breakaway system for our mesolimbic system. And I have this nice analogy to a resident. So really, the executive functioning functions like us. It does its best when it's rested, it's not stressed, it's got a supportive team environment around it. And unfortunately, modern society really chips away at our executive control. So overeating tends to occur at the end of the day, and many people may reflect on this and say whatever sort of dietary or eating pattern changes they've tried to institute tend to do really well until about 8 p.m. at night, and then all of a sudden things might take a bit of a detour, and there's very well established neurobiology behind this. When fatigue impairs our decision making. We also know that looking at patients living with obesity, they do have alterations in their cognitive functioning when it comes to making food-related decision making. It's almost like their brain circuitry has been hijacked and they're no longer able to provide that rational decision making around should I be eating this or not. Now, with adipose tissue here, we start thinking about white adipose tissue kind of secretes leptin, and this leptin and insulin binds to the arcuate nucleus, decreasing the drive for food intake, and it also increases energy expenditure through thermogenesis. During weight loss and decreasing adiposity, this leptin is downregulated and increases appetite while decreasing energy expenditure. So this increasing adiposity normally leads to the reverse picture, but patients with obesity can develop leptin resistance. And then we also know that compared to subcutaneous fat, visceral fat does decrease our insulin sensitivity, decrease the leptin release, as well as other anorexigenic hormones, and it's also pro-inflammatory. And then just a quick note on the gut. So these incretins that we'll be talking about with some of our novel molecules are secreted kind of by these L cells within the small bowel, and that's usually in response to food ingestion, and they help promote satiety. And then ghrelin, which is often kind of marketed as that bad hunger hormone, is secreted by the gastric fundus in response to this decreased gastric stretch during periods of fasting and low food intake. And then an emerging field is the gut microbiome, thinking about the whole acid metabolism and energy harvesting from our gut microbiome and the different bacterial profiles. And they've had some initial research looking at different gut microbiome populations and how that might actually be pro-obesogenic or help maintain weight. So again, this field's still in its infancy, but they're starting to think about things like fecal transplants and prebiotics and whether this may help provide any further interventions. So now a quick note on the calories in, calories out theory. So I think this is one of the more common misconceptions within medicine and within the general population, is that you just have to burn more calories than you consume, and that's how you maintain weight. And obviously, if it was that easy, we really wouldn't be dealing with obesity as a pandemic like this. And we know that's unfortunately, it's just too simplistic a picture, right? We're not just calorie burners. We don't just put energy in, combust them 100% and say, there's your energy, consumption and for the day. So we do have a lot of these different control mechanisms and metabolic responses, thinking about nutrition partitioning depending on the insulin response to foods, as well as we have asymmetric energy responses to different times of day when we're eating, as well as the response to exercise. And then the systemic inflammatory state as well also leads to decreased energy expenditure in many cases and can alter the metabolic profile in terms of energy absorption for patients. So this is something that, there's a lot of science behind it. And we know that the neurobiologic factors with our altered satiety and hunger signaling to certain foods can also impact and push the drive for overeating, even though we've consumed enough calories. So unfortunately, this calories in, calories out theory is something that we should try to dispel for patients, as it is also something that is quite a defeating conversation when they feel like it's all on them and that it's very easy to do. And yet we know almost all of our biology has been designed to avoid weight loss. This whole weight regain concept comes up quite commonly. You ask people about their journey with their weight management and with obesity medicine. And it very commonly comes up that they fluctuate around a certain set point, and this set point seems to slowly increase with time, regardless of what they try. And we know that we have this counter-regulatory hormonal response to weight loss that was initially an environmental and genetic adaptation to help protect our species during times of famine and food scarcity. So our basal metabolic rate and adaptive thermogenesis dramatically lowers in context of weight loss. And we have studies looking at over 6 years out post-weight loss, and our basal metabolic rate does not recover. Your body remembers the weight it was at beforehand and is not happy that you have lost weight and is still actively pushing back, trying to find ways to reclaim that weight. Same thing with these hormonal responses. So we know that this upregulation of ghrelin pushing us to feel hungrier and wanting to eat more, and the downregulation of some of our satiety hormones like leptin and GLP-1, this is long lasting, and that balance persists over years, even after trying to maintain a stable weight. Patients who have achieved significant weight loss are still battling this every day. It doesn't reset to normal kind of pre-weight loss levels. And then also this kind of reduced prefrontal inhibition leading to heightened food cravings when we've lost weight. It's kind of this internal drive to eat that's signaled centrally. So metabolic healthy obesity, this is a term that comes up, and there's kind of common media portrayals of this, and patients always ask, is it possible to be healthy and living with kind of obesity or overweight? And it's certainly an area of ongoing debate. It is typically seen as a transitory state. So while patients may be sampled at a point in time where we can't identify any metabolic complications of obesity, longer-term studies, when we look at different definitions of metabolic healthy obesity and looking at different sample populations, do show that there can be a wide range of quoted kind of prevalence of metabolic healthy obesity. But the more you look at it, it seems to be that as time progresses, many of these patients lose that metabolic healthy obesity status and they do develop cardiometabolic disease. And unfortunately, they're also at risk of non-metabolic related complications of obesity. So in some studies like the NHANES study, I mean, this is like 34,000 US patients looking at disease prevalence. They found that less than 3%, you look at the data, actually qualified as metabolically healthy when they used more strict criteria for insulin resistance as well as dyslipidemia profiles. And this picture of metabolic healthy obesity, it is more common in premenopausal women. And the characterization typically is lower ectopic and visceral fat, which makes sense. That tends to be more metabolically deleterious, but higher amounts of subcutaneous adipose tissue, typically in the lower extremities, as well as greater cardiorespiratory fitness and physical activity, as well as for whatever reason, they tend to have less of a systemic inflammatory response to the tissue that they carry. Another picture that might come to mind would be sumo wrestlers. When you think about these patients or these people, they tend to have very high amounts of total body fat percentage, and yet they have very low amounts of visceral adiposity. And many of them are actually quite metabolically healthy. But unfortunately, when we look at the data, patients with at the time diagnosed metabolically healthy obesity, they still have indications for weight loss as they're at higher risk of all-cause mortality and developing metabolic complications with time. And Obesity Canada does make a point to say we should not reassure patients that they are fully medically healthy. It's still important to start obesity management, not necessarily weight loss per se, but management of obesity and the associated cardiometabolic impacts. So the obesity paradox, this is something that has come up quite commonly in cancer and cardiovascular disease research, where typically less severe forms of obesity exist with improved survival benefit, especially with treatments, and that can be seen across a variety of diseases, especially advanced heart failure and certain types of advanced cancers. Now, it's often attributed to methodologic concerns, so things like the collider bias and lead time bias, and this is one of Dr. Hibbert's questions on his old Hibbert exams to explain the collider bias in the world of obesity medicine. But we do know that when using waist circumference or body fat percentages, many of these U-shaped curves disappear, and we have a monotonically increasing risk of mortality or adverse outcome with increasing waist circumference or subcutaneous tissue. Obesity Canada does highlight that there is about a 30% increased risk of all-cause mortality for every 5 kilogram per meter squared. So each BMI classification increase over a BMI of 25, which is typically seen as overweight. So this is an important area to kind of dispel misinformation, saying that gaining weight is not protective for your cardiovascular health, and it's something that may have been a bit of a statistical error when we start thinking about how we looked at the outcomes. And it also makes sense when we start considering some of the heart failure data. Patients who present with heart failure and obesity tend to have more severe symptoms, and they'll present younger when they're less frail, and they tend to do better with treatment interventions. So this kind of lead time bias becomes an important consideration. And the same thing with cancer, right? These patients are caught earlier because they develop more aggressive forms of cancer, and they tend to be less frail and respond better to initial therapies. So let's focus now on obesity and cardiovascular disease. And it's important to acknowledge that obesity has interplays with atherosclerotic risk factors as well as established cardiovascular disease. So adipose tissue in the cardiovascular system. There's bidirectional signaling between adipose tissue as well as the myocardium and the vascular walls. They're able to influence each other outside in and inside out. So this adipose tissue dysfunction leads to insulin resistance, altered lipid profiles, and chronic inflammatory states. And then these adipokines, which are typically pro-inflammatory and pro-atherogenic, are secreted by the visceral adiposity and can have negative impacts on cardiovascular disease when it comes to atherosclerotic disease, as well as development of things like diastolic dysfunction and HFpEF. But we do know that in response to endothelial injury or elevated BNP, we can actually switch to a kind of anti-inflammatory and anti-atherogenic environment. And adipose tissue can produce altered types of adipokines, including things like adiponectin, which can be quite beneficial in patients. So there may actually be some protective effects for certain fat storage depots. And it's an area of interest for some research groups to see, can we harness adipose tissue if we can't get rid of it, but to improve the metabolic response. Now, obesity and atherosclerotic risk factors, just kind of a quick overview. So about 80% of patients with type 2 diabetes have overweight or obesity. And then these patients living with obesity are 3 times more likely to develop diabetes. Lifestyle interventions can be effective at just modest weight loss and then improvements in A1C around 0.7%. When it comes to hypertension, we know that this visceral adiposity is most closely related to systemic and arterial hypertension, and it's mediated through this increase in aldosterone secretion through the peripheral adipose tissue, increase in vascular wall stiffness, increased sympathetic nervous system response, as well as this renal vascular compression leading to increased renin release and the activation of our RAS system, as well as the associations with obstructive sleep apnea. And we found that about 5 to 10% weight loss through lifestyle interventions can be associated with about a 5 millimeter of mercury reduction in systolic blood pressure, and that this does tend to increase with greater weight reduction. And then when it comes to dyslipidemia, common lipid profiles seen would be hypertriglyceridemia, increase in ApoB, and small dense LDL and lower HDL levels. And the weight loss can reverse this profile to an extent with a more dramatic impact on triglyceride levels, about 20% reduction to get to a 5-10% weight loss. The ESC does recommend that we're looking at ApoB, and I'd say practically non-HDL cholesterol is probably a reasonable way to look at it, especially when we think about the prevalence of hypertriglyceridemia, and when triglycerides over 1.5 LDL should be avoided is not an accurate estimation. And then there's more recent data out of the European Heart Journal. They've studied about 35,000 patients with FH and found that those living with obesity were associated with more severe lipid profiles and a higher incidence of atherosclerotic disease than those with the same lipid profile but without obesity. This is just a quick kind of snapshot from one of the Obesity Society journals, where they did an analysis of the STEP trials looking at semaglutide involvement. And they found that semaglutide, the 2.4 milligram dose weekly, patients treated with this were more likely to have their lipid-lowering therapy and antihypertensive therapy dropped or actually removed during the duration of treatment. So something that patients may be interested in with this pill burden these days. It's always nice to know that while treating the underlying drivers of their kind of atherosclerotic risk factors, we can lower other therapies. So they had about 18% of patients who were able to come down on their hypertensive therapy, as opposed to 9% in just the lifestyle and placebo groups, and about 10% versus 5% were able to lower their statin therapy. So in terms of coronary artery disease, obviously there's risks associated with the atherosclerotic cardiovascular disease risk factors that are worsened in obesity. But then there's an emerging body of evidence recognizing that obesity is an independent risk factor for atherosclerotic cardiovascular disease. Now, it's thought to be mediated by this low-grade systemic inflammation, which makes sense when we start thinking about patients living with chronic inflammatory conditions and the increased risk of atherosclerotic disease there, as well as this interplay with the highly metabolically active adipose tissue in the epicardium and how this can lead to local epicardial coronary inflammation. And there's also associated microvascular dysfunction, impairments in nitric oxide production, and altered sympathetic nervous system response. And then we have some cohort studies and registries that indicate traditional atherosclerotic risk factors. The risk is only accounted for by about 45 to 65% of the risk seen in patients living with obesity. So that kind of raised our antennas to, is obesity an underlying risk factor? And we do have Mendelian randomization analyses now that do support causal relationship between genetic forms of obesity as well as the increased risk in coronary artery disease. Now, in terms of its practical implications, ultimately we treat patients with coronary artery disease and obesity, and especially ACS, the same as patients without extra adiposity. While there is some evidence that there's higher platelet reactivity testing that may be related to this pro-inflammatory state, there's no evidence right now suggesting higher doses of antiplatelet therapy. And then we do know that there's some registry data suggesting that patients with more significant obesity are more likely to develop contrast-induced nephropathy as well as vascular access site complications with PCI, which does make some sense, thinking about the technical difficulties of the procedure, and unfortunately may be associated with higher in-hospital mortality when they present with STEMI. So with heart failure, especially heart failure with preserved ejection fraction, so we know about 80% of patients with HFpEF will be living with overweight or obesity, and that they develop a greater symptom burden, more frequent heart failure hospitalizations. And then there's an increased all-cause mortality in patients with HFpEF as we look at increasing waist circumference. And we think that, HFpEF results from the systemic inflammatory system with metabolic dysfunction, the development of microvascular disease. And the pathophysiology also includes this intramyocardial lipotoxicity with myocardial steatosis, similar to things like hepatic steatosis, then LVH, as well as atrial myopathy, and then these adverse neurohormonal adaptations that we mentioned when talking about hypertension. So this is just an ESC diagram here outlining some of the underlying pathophysiology that relates to the interplay between obesity and HFpEF. And we also know that obesity with type 2 diabetes is associated with more severe forms of HFpEF, which makes sense when you start thinking about the clinical populations you've seen with more advanced forms of HFpEF. So note about natriuretic peptides in obesity. So it's common knowledge that we see lower NT-proBNP levels. It does tend to be due to an increase in the peripheral uptake through the expression of these natriuretic peptide receptor A's, as well as a lower release in association with this increased insulin resistant state. There's an attenuated BNP activity as well. So what BNP is in the systemic circulation does not tend to provide the same positive cardiovascular benefits due to this reduced intracellular activity. And then the ESC has advocated for a while now that we consider, lower BNP cutoffs, so 50%, not yet validated in cohort studies. We always have to keep a heightened suspicion for HFpEF when dealing with patients, as we can't just rely on the biomarkers. And, we can use clinical markers such as the H2FPEF score, but really the gold standard is trying to identify forms of congestion. So I know in clinic with Dr. Risk, we've had some patients where it's very difficult to tell how much of the symptomatology is due to obesity versus lung disease, and trying to find that evidence of an elevated JBP with careful clinical exam, and even have to refer one patient for exercise right heart cath testing, and you find that their wedge goes up to 35, and it all of a sudden makes a lot of sense, while their orthopnea and P&D and exercise intolerance. So it's just to keep that at the back of your mind, that just having normal natriuretic peptides is not just a quick and easy way to discount, or at least to attribute symptoms just to obesity. So a note on incretin-based therapies in HFpEF, and we'll talk a little bit about this later on, but we know that we have good data now through the STEP HFpEF and STEP HFpEF diabetes trials, that these higher doses of semaglutide, the 2.4 milligram doses, can be associated with improvements in quality of life, seen through improvements in the KCCQ scores, as well as 6-minute walk distances. And an interesting point to note, when these trials first came out, people were saying, well, it's really not surprising. If you lose weight, you'll feel better, especially when these symptoms are things like exercise capacity and breathlessness. But we know from some larger studies, like the Look Ahead trial and bariatric surgery trials, that when we achieve significant weight loss, like we were talking about with natriuretic peptides, we would expect our BNP levels to rise as we've removed this extra adiposity. And yet when we treat patients with GLP-1 receptor agonists, despite significant levels of weight loss, their BNP levels drop. So it's not that they just didn't go up, they also drop, leading further credence to the underlying mechanisms that there is independent cardiovascular benefit for heart failure. Now, we also know that these more recent dual incretin therapies that are not yet available in Canada for heart failure management, or at least licensed for heart failure management or obesity management, but things like tirzepatide. With our Summit trial looking at kind of the 15 milligram dose, we again have reduced time to cardiovascular death, worsening heart failure events, as well as improvements in exercise capacity, as well as patients' quality of life. And we see improvements in systemic inflammatory markers like high sensitivity CRP, as well as quite significant amounts of weight loss. Now, there was a Summit MRI sub-study And they did identify that there was about 11 gram or 45 milliliter decrease in pericardiac adipose tissues. They're trying to come up with, biologic and pathophysiologic mechanisms for why patients may feel better and experience better heart failure outcomes. Now, heart failure with reduced ejection fraction is less of a strong association, but we do have some Swedish cohort studies indicating that especially men are at higher risk of developing dilated cardiomyopathies when living with obesity. And we do have to keep in mind that more advanced forms, especially heart failure reduced ejection fraction, are strong catabolic state. So some of the lifestyle interventions and caloric restrictions that may be discussed in patients that kind of live in a nutrient excess environment can be dangerous for these patients. But we do have some small RCT data supporting the fact that patients may feel better with improvements in their NYHA class status with weight loss in heart failure reduced ejection fraction. And we also have some data now from the SELECT trial with use of that semaglutide 2.4 milligrams daily in patients living with overweight or obesity without diabetes and a wide range of cardiovascular disease, including heart failure with preserved and reduced ejection fraction, that their kind of secondary endpoints indicate MACE reduction seen in both of these populations of patients with heart failure. Now, when it comes to arrhythmias, there's really 2 points to discuss. The most pressing would be atrial fibrillation, and we have data to support a dose-response relationship between adipose tissue and obesity classification, as well as the incident level of atrial fibrillation. This comes from some cohort data as well as Mendelian randomization data. And there's also an association with progression of disease burden from paroxysmal to permanent atrial fibrillation. It's thought to be mediated through this left atrial dilation and diastolic dysfunction, with this periatrial adipose tissue associated with atrial fib burden independent of BMI, and thought to be some local inflammation and paracrine signaling that could be pro-arrhythmic. Again, still investigational. And like our AFib CCS guidelines here, it relies on some of that legacy trial data supporting the fact that we start to see the greatest improvements in AFib burden with weight loss over 10%, especially when we're avoiding significant weight gain. So that's another point I try to make is while obesity is a chronic relapse remitting disease, if we're able to achieve stable weight loss, these are the patients that tend to experience the greatest benefit in terms of the AFib burden, which is unfortunately diminished when they have periods of weight regain. And then a quick note, so DOACs, they are preferred to warfarin in those with class 3 obesity, but warfarin is still preferred over DOACs in patients after metabolic or bariatric surgery due to concerns regarding DOAC absorption. So arrhythmias and sudden cardiac death, I know we're running short on time here, so most of this is association data. It's kind of hypothesis generating and interesting just to know that there is this relatively strong association between sudden cardiac death and obesity, and that we can see electrical changes on ECG after weight loss. Valvular heart disease, so there is an association with incident AS, and we do have some genome-wide and phenome-wide data to suggest that it is a causal risk factor for the development of aortic stenosis, and that there are worse outcomes in patients with more severe obesity undergoing TAVI. But we don't yet have any outcome data suggesting weight loss improves outcomes post-TAVI. So approach to obesity treatment, 5 A's of obesity management. So there's kind of a whole pathway to follow here. And again, running low on time, but Obesity Canada Guidelines 2020, they have a very nice 5 A's framework in one of their supplementary appendices that can help walk you through an approach to discussing obesity management with patients. So this is just an important point. When we talk about the goals of treatment, it's really obesity management and not weight loss, as we know that many people will derive benefit from the management and lifestyle and pharmacologic interventions, even independent of overweight loss. And our goal is really to restore function, reverse and control obesity-related disease and improve patient-related defined quality of life, what's important to them. So the Canadian guidelines make a point of we're not there to specify a specific amount of weight loss. Patients can be quite fixated on this and be defeated if they don't achieve that weight loss, but really we're looking at overall health outcomes. On the other hand, the ESC guidelines with a practical approach to cardiology do suggest most of the benefits seen with about 5 to 10% weight loss. Management tools include medical nutrition therapy, physical activity, and pharmacology, as well as metabolic surgery. And this is really based around that Edmonton obesity staging system. So when you have a chance to help classify them from stage 0 to stage 4, it gives you insight into what you should be advocating for patients. And typically those with less severe impacts, with the stages kind of 0 to 1, it's more focused on lifestyle interventions. And when we start getting to stage 2 and beyond, then we should be harnessing all forms of therapy, including pharmacotherapy, as well as metabolic surgery referral. So medical nutrition therapy, really rely on your dietitian friends. There's lots of information regarding this. Unfortunately, as cardiologists, we're quite ill-equipped with the knowledge to provide detailed counseling with patients. But I try to take a kind of broad perspective approach and discuss with patients that it can be very helpful for improving their overall health, while in the long run, these hypocaloric diets have not been proven to provide any significant or durable weight loss. And that there are lots of resources for different dietary approaches that can help improve cardiovascular disease. Some of these patterns are outlined in the ESC document, and a lot of them tend to be focused around whole food, plant-based diet or eating patterns. So I reassure people that can include dairy, meat, eggs, seafood, but it's really emphasizing the healthful foods and then filling out the rest of the diet with foods that they find palatable and can help ensure adherence in the long run. This is just some data here looking at specific sub-diets that provide the greatest or least benefit for outcomes such as weight loss, blood pressure control, and lipids, with some of the most profound weight loss being seen in the short term with lower carbohydrate, higher protein diets, and some of the best reductions in LDL cholesterol being seen with vegetarian dietary patterns or things like the portfolio style eating pattern. This is just a nice summary picture that's provided for patient education on Obesity Canada. And it's nice to use this in broad strokes terms when discussing what eating patterns may look like, thinking about being mindful while eating, cooking more often, enjoying your food with others, and thinking about reaching more for whole food, vegetable-based diets, more plant-based proteins if possible. There are some free resources with whole medical culinary guides available to us. So physical activity, again, a whole discussion of itself. I put together just a quick table using ChatGPT as I couldn't find a nice one reference, because I find patients kind of ask, how do we approach this? And from our perspective is just knowing we have the same physical activity recommendations for obesity medicine as secondary prevention of coronary disease. And I kind of highlighted here, based on the studies, where our light activity, kind of that is usually recommended, and kind of our moderate intensity activity is. So we can use this kind of talk test for patients. They have a rough idea when they're in the gym, if they don't have access to smartwatch devices and heart rate zones, how can they gauge their pace? And where does that fall in terms of this more popularized 5-zone training model that a lot of these fitness trackers will be advocating for these days? So I'll kind of jump through a lot of this. Unfortunately, I kind of ran over time, so I apologize for that, but lots of information with pharmacologic management. Most of this relates to the cardiovascular benefits of semaglutide and the emerging benefits with tirzepatide. I put together a reference sheet, so a double-sided reference sheet outlining everything from indications, costs and coverage, common side effects, how to counsel patients and manage common GI side effects, as well as, cautions for patients in which patient groups may not benefit the most from these, as well as expected weight loss, what might happen if patients stop medications, and how to manage those that don't achieve a certain degree of weight loss. So if you're interested in this resource kind of to help support you in clinical practice, just let me know, and hopefully it can help encourage us to provide information for patients and increase prescribing amongst our patients living with obesity. And then just a last quick minute note on the BRAVE study here. So Dr. Mears, our local PI, taking over for Dr. Melnichuk, and we've got observational data supporting decreased mortality and improved improve cardiovascular outcomes in patients with cardiovascular disease undergoing metabolic surgery. So we're currently exploring whether this compared to medical management may provide robust RCT benefit to our patients. So I'll just leave you with a few take-home points. And again, sorry for going over time, but thank you for your attention.
Thank you so much, Keiler. That was excellent. Very in-depth overview and a problem we face daily. We are out of time. So if you do have questions, please come up to speak with Keiler. I'm sure you're able to stick around for a few more minutes. Otherwise, have a good week. We'll see you next week.